With most chemo, only a tiny fraction, like 2 to 5%, ever actually reach the tumor. That means the rest of the 95% is going to harm organs and to destroy the immune system as well. So, what if we could flip the entire game? Go so much smarter and deeper, direct to the tumor without the same toxicity, and with a targeted immunotherapy using minimally invasive type of surgery. What if we could send an immune-centric medicine that creates an immunosystem response to the body straight to the tumor? Now, we'd have 95 to 100% of the medicine getting right where we want it and where we need it, turning cold tumors that are invisible hot so the immune system can fight the cancer. Today, I'm going to break down an exciting breakthrough in oncology with a paper that my team and I just published on a stage 4 advanced cancer and how Chemo-Immuno Precision Injection, or what we call CIPI, represents a critical milestone in precision oncology for most solid tumors. So stick with me. I'm going to walk you through the transformation in oncology with going direct to tumor, the advantage that it gives, and why most oncology patients will miss it altogether, because this is using the state-of-the-art and interventional radiology oncology to change cancer. I'm Dr. Dino Prato, founder in Vita Medical Centers. For the last 25 years, my team and I have helped thousands of patients, many who have failed conventional integrative medicine and were told there was nothing else that can be done. But here's what the key is. It's the immune system, and it's getting the medicine to the right parts of the body. What I'm sharing with you is real clinical experience. We've treated many, many thousands of patients over the last 25 years, and this is not just a published paper. This is real care, not theory, and it really makes a difference. And this is for educational purposes only, so make sure you talk to a doctor before changing any medical care. So let's get started. People will take a drug regimen from the National Comprehensive Cancer Network guidelines based on double-blind placebo clinical trial models. This is really the one-size-fits-all. Based on the tumor type and stage, this is really population health, not individual for your unique cancer's biology or immunological footprint, which is really important. Even in the research models, when chemo is delivered through the bloodstream, the tumor may only take up less than 5%. And in some aggressive and tumors that have stromal barriers, it's less than 0.07%, so even less than 1%. So where's all this medication going? It's going to healthy organs and the central nervous system. So this type of technology is so important because when you do high-dose standard chemotherapy that is not detailed type for you, you're not getting the right drug to the right place. It's going after healthy tissue, central nervous system, creating side effects because it's not directed to the tumor. And that's a big deal. So most of it's not getting to the cancer. Secondly, we know based on the data of many thousands of patients that 90% of the patients who came to us, they were on the wrong chemotherapy because they didn't have the right testing. And this pushes resistance. It destroys your immune system. It also can cause evasion. So this is important. Third, rarely is a therapy immunogenic, meaning it's not designed for your immune system to do the work, because the first and last defense against cancer is immunity. Even way beyond chemotherapy or radiation or surgery or even an integrative agent, we want the immune system to do the work. This is where we see long-term responses. Even when you're using metabolic tools to shrink the cancer, ultimately the immune system needs to do the work, meaning we need to take cold tumors and turn them hot so the immune system can see it. And this is why many patients get crushed in the area of chemotherapy and side effects. They get fatigue, organ stress because of these high doses. They get a bad quality of life, and the cancers adapt and they evade the immune system, and we have refractory or resistance to care. So these are the disadvantages. We see all of these in these points I've just went over. So this direct-to-tumor technology helps us to get away from these disadvantages and turn them into an advantage, something we need. So the breakthrough here is direct-to-tumor interventional radiology oncology. You've heard me talk about this before in my other episodes, CIPI, Chemo-Immuno Precision Injections. In our recently published paper, we demonstrated a technique in this case study, but we've used it to help many patients. It's minimally invasive. We call it invisible surgery because essentially you come out with a Band-Aid and you're using a catheter the size of your hair, or you're going percutaneous with a tiny needle to the tumor. So it's very small. There's not the surgical cut. There's not the opening. There's none of that. It's really direct. And we're delivering targeted agents, which I'll get into here in a minute. But the idea here is not only to kill the cancer with precision and turn on the immune system, but protect the healthy cells of our body. So while we're taking these cold tumors, if you will, hiding from the immune system, we can turn them on. We're revealing the information in the tumor to the immune system, and I'll show you why that's important. And finally, with this, the immune system knows what to do and goes after the cancer because the treatment was custom built on the patient. So this is N of 1, not population health, one size fits all, double-blind placebo clinical trial. It's N of 1. It's custom built for each patient. So Chemo-Immuno Precision Injection, that's what's helped many of our patients. And I think of it like this. Instead of pouring drugs through the entire body and hoping they work and they're selected on a population health strategy, this is delivered with precision precision based on mutations, metabolic function, and most importantly, immune-centric, overcoming the immune evasion of the body that can happen with cancer. It's accomplished in two powerful steps, something you've heard me say over and over again: deep testing, multi-omics. So not just next generation sequencing. You'll hear people tell you, oh, you need to get biomarkers. That's a very small portion of tests and small portion of drugs that work on actual biomarkers. And oftentimes they just slow cancer down. They don't actually get rid of it. But what we really need beyond that is also full transcriptomics RNA. So now we're into 1,000+ markers. And then here's the key: immune profiling. So we understand how the cancer is hiding from the immune system. It's like running a drone over the tumor so we can see the neighborhood outside the cells, but we can also see inside the cell. And we can make this information available to the immune system so it can finally see the cancer. But we need to know what we're looking at. So we're not just randomly giving a PD-1 inhibitor or some other immunotherapy drug or even an integrative agent. It needs to be typed. So instead of the standard 24 markers of a biopsy and imaging, and if you're lucky, a couple hundred extra markers on DNA, we're running thousands of markers. And we're moving away from a treatment plan that's cytostatic, which is mainly designed to slow the cancer down, and moving to cytotoxic. So in the algorithm is designed to kill the cancer. That should be what we're all aiming to do. I think it's fair to say that every doctor's goal and patient's goal should be to eliminate the cancer. And the key to that will be, in my clinical opinion, through immunotherapy as one of the key points. So then when we have all that data, we can custom build the treatment and the medications in our pharmacies that are precise for the patient. This isn't something you're just ordering from big pharmaceutical companies and then mixing them in a bag. You're custom developing them because you have on-label, off-label, integrative immunotherapy drugs, phytotherapeutics, all combinations that are precise for that patient. And then, like a fiber optic, a tiny little catheter the size of your hair goes right into the tumor to deliver 95% or 100% of the medication, or an injection straight to the tumor, with the goal of not only killing the cancer, but making the tumor visible to your immune system, because we're basically biohacking the tumor so that it can be visible to be killed. So this is important, getting rid of that cloaking mechanism. And that's what CIPI does. Chemo-Immuno Precision Injection is designed specifically for that. And so then we come out and you get a Band-Aid because you really don't have surgery. And that's why we give it the term invisible surgery, because it has very minimal effects. There's no cutting. It's very quick and it's very precise. And we use 3D cone beam, which is these incredible visualizations so we can see all the blood vessels, see the tumor, see it all in a 3D format and moving so we can get right to the tumor. And we get to the metabolic active areas of the tumor where we know it's growing, spreading, and we know the heat map signatures within the tumor and outside the tumor to custom build the medication. See, that's real precision. And that's why this study that I'm about to go over with you is pretty important, because this is the key part to what we do in CIPI. So CIPI, Chemo-Immuno Precision Injection, or what I like to call fracking the tumor. Fracking is like when you're drilling for oil and you have to cut through all the nonsense and the clay and the plate so that you can run pressurized water to release the oil. Well, in this same way, we're fracking the tumor so we can release the neoantigens, we can release tumor fragments in DAMPs, damage-associated molecular patterns, all the information in and around the tumor, plus stop any of the blockades that are around the tumor. Maybe, as I've said before, there are gangs preventing the police of your immune system getting to the tumor, and taking those out so the immune system can do its work. Sometimes there's PD-1 inhibitors, but what people don't really understand in the world of immunotherapy is that PD-1 inhibitors maybe work long-term 10% of the time. If you look at studies like Frontiers in Oncology, and they give us maybe 10 months of longer quality of life because there's no testing being done to actually see what is the PD-1 saturation in and outside the tumor, and if we need it at all, or if we need a different mechanism that we need to do on or off label to go after resistance. So with that, then we're able to build the treatment, use the technology, frack the tumor, get it open, get that information to the immune system, and now make tumors that were cold hot and the immune system better to work. And in fact, we can add other immunotherapy adjuvants in there to really help the immune system work even better. And all with precision microdosing. We don't need big doses, and we can avoid tremendous side effects going to healthy organs, central nervous system. And when we treat one cancer, the goal is to get the systemic effect throughout the body. So this is really important. For years, what we saw was patients doing IV chemo not responding well. And so we realized, wait, cancers have lots of barriers. And as testing in decades of work, we realized there's a lot of stromal barriers, a lot of resistance to these tumors. And getting direct to tumor with image-guided procedures really made a big difference for our patients. And so that's what's at the core of this. It's stopping the fog around the cancer and treating it like a target specific to the patient. And it's using interventional radiology oncology, which I think is like the fourth branch of oncology, or the fourth pillar, to really getting targeted to cancer. But you need the right drugs and the right targeting as well, so that you can precisely deliver what you want in the right areas. But hospitals rarely use interventional radiology oncology. It's mainly for palliative care, but there's no work as a centralized treatment strategy. Mainly everything today is surgery, it's chemo, it's radiation. It's kind of outdated in my clinical opinions when we can precisely go to the tumor, shut it down, freeze it, alter it without harming the body. So this is an important case history because this patient had widespread metastases in a very large tumor. Now we have many cases. I'll present more of these cases to you in the future. In fact, we have many, many cases. We've been doing this for a long time, but this case is particularly nice to share because it was a large tumor. Because most of the argument people have with direct-to-tumor is, what do you do when the tumor is large? Does it work? Does it work as well? And the answer is yes. And that's what I'm going to show you why this case has widespread metastases and a very large tumor, making it important for a case history to explain the power of interventional radiology oncology and chemo-immuno precision injection, which we use with our patients. So here we have a 67-year-old man in the study with stage 4 metastatic, high-grade, poorly differentiated small cell type neuroendocrine carcinoma. Lots of words, but stick with me. I'll make it simple here. It's a neuroendocrine tumor. So it's a rare type of cancer that forms from the neuroendocrine cells, and it has the traits of nerves and traits of like hormones, and it can develop in many areas of the body. And in plain English, this is what this cancer looked like. Fast growing, very, very aggressive, already spread to other areas of the body, and often this type of cancer is very hard to control. The imaging here was amazing. He had a 17 by 13 centimeter tumor in the liver. So consider the size of that tumor. Anything over 5 to 10 centimeters would be deemed a large, giant tumor. This thing was 17 by 13, huge. And the biopsy data showed us a Ki-67 of 98%, which means that 98% of this tumor was spreading, was active, was prepared to divide. So it means it's very aggressive. And so this is a type of cancer that'll have a poor prognosis, maybe if a patient's lucky, months or a year to live, and that's if they're fortunate. So this is a difficult cancer, and this is where a technology like precision oncology can change the game. So he didn't want to do surgery, and he didn't want to do chemotherapy, standard care. He basically denied both, and for good reason, because surgery of large tumors can carry lots of risks like bleeding, infection, other complications like pneumonia, bile leaks, blood clots, potentially could be life-threatening. So in this case, the patient opted out of those risks and wanted precision oncology. And with that, it was so important because we started with deep testing, like I just went over, and then we went direct to tumor, focusing on getting the patient well. Now, this is not all we did, but this was one of the important components to the treatment plan to helping this patient. Of course, we also used, if you want to go back and look at episodes on genetically targeted fractionated chemotherapy and immunotherapies that we used, but this treatment was so important for the patient and really worth building a case history for in this published paper so that you could see how it works on large tumors, and other doctors can read about it as well. So here's what our clinical workflow is. First, we want to map out, it's CT imaging, PET scans. We want to look at the tumor, this location, what's going on there, because that's important. We want to be in the most metabolically active areas, but that's just the beginning. Then we want our full mapping, DNA next generation sequencing. In this case, it was NGS. In all the cases that we've done, because this is an older case, we now are much more advanced. We're using transcriptomics, 1,000+ markers. We have spatial biology with full laboratory immune profiling that you really don't see anywhere else. We can see the tumor's immune system and see all the targets that it needs. And that directs the care to our Chemo-Immuno Precision Injection, or this process we call CIPI, so that we can get straight to the tumor with what you need, immune profiling and direct delivery. Now that we have that data, our pharmacy will custom build the medications so that they're targeted and given in the correct order during the procedure, so it goes right to the tumor. That's important. I want you to hear that again. It goes right to the tumor. So we're getting it in the tumor, around the tumor, in the metabolically active areas of the tumor, and it's almost like an invisible surgery. We call it minimally invasive in interventional radiology because it's going in with a catheter the size of a hair or a needle that's very small, and you come out with a Band-Aid. So you don't have all the cutting and all the risk of infection and all these other complications because you're precise. In this case study, we had CT-guided pericutaneous injections, okay, which is great. But today we have 3D cone beam, which is like 3D imaging. You can get around the tumor, see it, and map it all out, see all the blood supply of the tumor, and be so precise that you're directly in the belly of the beast without harming any of the other tissues. And you can go right shutting down the blood supply to the tumor or go direct to the tumor, all with the goal of stimulating the immune system using a catheter the size of a hair. So almost like an invisible fiber optic, if you will, and 3D imaging. So this is really powerful. And this is a step up from the old CTs where you have a 2D type X-ray. With 3D, you visualize the whole entire tumor. You can see it all spinning in a 3D environment and go right into the tumor and avoid the tissue that you don't want. So we're avoiding cutting, and we're doing it all with screens so we can see the tumor during the time the medicine is being administered. Now, we've delivered the medicine using this technology and visualization, which is second to none. Now we're able to do what I call adaptive monitoring. In standard oncology, you're always waiting for a tumor marker imaging. I call those lagging indicators. They're the last ones to appear. But with our patients, we're looking at leading indicators. What are those? CTC, circulating tumor cells, CT-free DNA. So let me go over these in more detail. We're constantly tracking the patient's symptoms as well. So the patient has a reported outcome we call a PRO score from their own words. How are they feeling? So how much are they improving? Because that's quality of life. At the end of the day, that's so important with late stage cancers, is getting people to feel better, have a better quality of life and a longer life, so we can track that score. The circulating tumor cells shows us how much of this cancer has stopped spreading. Tumor methylation score, same idea. We're shutting down the mutation and variation of the tumor. Variant allele frequencies on CT-free DNA. So we're able to look at all these markers. And when you look at this case, it was kind of jaw-dropping because everything improved. The patient-reported outcome almost immediately went from 35 to 17 in symptoms, which means over a 50% improvement in quality of life very quickly. Now remember, this is just part of the treatment, not the whole thing. And that's huge because we've improved the patient's quality of life and we basically have shrunk the tumor in more than half very quickly with one procedure. The circulating tumor cells went from 40 to 0. This thing isn't spreading. It's not seeding into the bloodstream. We've shut that down. So now we've got the immune system engaged and the tumor shut down. Tumor methylation score went from 25,000 to 1,900, showed a 92% decrease in the ability for the tumor to try to methylate or mutate. We also saw what's called variant allele frequency. I don't want to say complicating words. Went from 39% to 6%. A great reduction there because it shows us that the DNA signaling is dropped. So in every aspect, the leading indicators are showing us a patient is going into a positive response. And that's critical. We don't have to wait months for that. We can see this in a matter of weeks. The leading indicators are going to show us that we have positive lagging indicators. This is important because when you have this ability to adaptively respond to what you see, you can help the patient. So the tumor itself shrunk. It was 17 by 13 centimeters down to 9 by 7 centimeters. So that's a significant reduction, almost half of it in one treatment without the side effects. The PET score improved as well, showed a huge reduction in the uptake of the tumor's metabolic activity. So everything in this case was very important for CIPI because it shows you that, yes, this is killing the tumor, it's getting the immune system engaged, shutting down the mutation of the tumor, and we're moving in the right direction. Also, the tumor became stable. So what does that mean? When the tumor is stable, the disease in the cancer isn't growing. It really isn't really shrinking anymore either, but it significantly has like blocks all around it. It's not going anywhere. And we've got the patient in that stable part of the disease. So now we can incorporate other important pieces like immunotherapy or look at other metabolic functions. See, one thing that patients don't understand is that when you have a large tumor, particularly like a neuroendocrine, different parts within the same tumor can have different genetic pieces of information, different mutational drivers. And so as we're shutting the cancer down and we gather the new information, we're able to go back in and hit those new drivers at the right time and continue to help the patient respond. So this phenomenon is known as tumor heterogeneity. You remember me saying in other episodes that you can have two people with the same type of cancer have total different markers? Well, you can have in the same patient, in the same cancer, have different markers, even in different parts of the body, different markers. So those play an important role when you have these fast mutating aggressive cancers. So CIPI allows us this powerful treatment to shut the tumor down quickly, identify heterogeneity with our advanced testing, and then custom design the immunotherapy to help the patient, bringing them into a more stable disease by debulking it. That's why this case history is so important. But even more importantly, the quality of life improved immediately, and cold tumors became hot again because the immune system was able to do its work. Let me explain this from a immunological point of view. This is why CIPI is so important. In the world of oncology, we've been told, oftentimes patients will have a cold tumor. They lack the right ID badges on their markers, or they don't have any, or we're told about all this major histone compatibility problems. We can overcome so much of that effectively when we can go direct to tumor. Because the conventional wisdom suggests if you don't have the right ID badge or mutational rates, you're not really a candidate for immunotherapy or a PD-1 inhibitor. But this view is very limited because it relies on the tumor's passive state. To truly move the needle in this aspect, no pun intended, we must move beyond the static limitations of DNA sequencing and look at RNA transcriptomics and immune spatial biology so we can lyse or bust the cancer open and release all that rich information to the immune system so it's no longer invisible and cloaked. Now we can see the information. The dendritic cells are able to capture all that information. You've heard me say this before. The dendritic cells are like our investigators. They're basically going around looking at mug shots, fingerprints, fingerprints, data, information, and they're passing that on to our T cells and natural killer cells and giving the body the ability to aggressively target. When we have this right concert of immunity and we use other nutritional and important aspects in integrative care, we can also build memory on the T cells, so we're not just getting a short-term response. This allows the machinery of these new antigens to be presented in a way while we're able to stimulate the immune system. So we're lowering the tumor burden, the mutations. We're going after the cancer. We're recognizing how much, PD-1 or blockades are involved, or what are the other blockades in the tumor, and we're able to shift that environment all during the Chemo-Immuno Precision Injection through our algorithms of testing and custom drug development. And then this helps us to reveal what's the real problem with that tumor and how can we overcome it. That's the goal. So if we don't change the tumor microenvironment and we don't customize immunotherapy simply, you could have a very expensive immunotherapy drug just circulating through the body, really going nowhere, or doing very minimum work. Might kill a little bit, stop working. But to really impact cancer in its long term, we need this kind of adaptive response, because these cold tumors become hot and we get a nice kill, and then they may mutate, or we can change that with adaptive monitoring. And CIPI, which is this technique, the Chemo-Immuno Precision Injection, allows us to release this cargo into the immune system with precision, and then at the same time give the immune system what it needs to grow, expand this information, the damage-associated molecular patterns, all the antigens, the neoantigens, all the hidden debris, if you will, the tumor products that are there, and it creates a natural vaccine within the immune system to go after that cancer and any other cancer cell in the body that looks just like it. See, we're giving the body information, not just attacking it. And so this is important. So even today, when you look at some of the great drugs that are coming out with micro doses of immunotherapies that are on the market that are going straight to tumor, is a very powerful way to use those depending on the markers that you have. So we don't just wait for the immune system to notice a debris or to be evaded. We give the immune system the ability to flip its switch, recognize it, and go after the cancer. That's the power of Chemo-Immuno Precision Injection. And in this patient, you saw they stabilized. They did very well. We're able to see, did they need a PD-1 inhibitor? Do they need any other care? The natural killer cells are able to do their work. T cells, all the lac cells, all the parts of the immune system supporting the body to build memory through key phytotherapeutic adjuvants. So now we're changing the game of immunotherapy. And when you really understand this process, in my clinical opinion, it blows away any immunotherapy drug in the market, because we're customizing a variation of what the patient needs specific for them. So by focusing on these tumor fragments and getting this right information to the tumor, we're able to make these tumors visible. Regardless of MSS or MSI or microsatellite stability, etc., we can overcome those things. That's the power of CIPI. So why does that matter? Because if you go back and look at our 2024 paper, and we have another one coming out, you'll see this is why we got the responses of 199 late-stage cancer patients, where we had a 35 times better response than conventional standard of care oncology with late-stage cancer patients, and a 43-time better quality of life. It's all based on this type of targeting. Our patients felt better, better quality of life, better response because of targeting and immunotherapy. This isn't going to happen in the big pharma model, because big pharma is looking for one drug they can produce in an ampule, or an IV chemo that they can do, or even an injection, and sell it worldwide. This revolves around customized and detailed planning by each patient. This is N of 1. So it's not going to be something you can mass produce, but you can customly build for the patient. So here's what I think you need to take home from this study, and you're welcome to read it. If your doctor's using National Comprehensive Cancer Network guidelines, realize that's population health. That's one size fits all. It's not specific to you. And if you're told there are no immunotherapy options, that's likely not the case if you haven't done full N of 1 precision oncology multi-omics testing. If you haven't done that, where you know all of the immune profiling, spatial biology, transcriptomics, and full next generation sequencing biomarkers, you don't have the 1,000+ markers to guide you. So don't be discouraged. Get the right testing. That's going to help a lot. And precision medicine is not just about the right drugs and the right targeting, like I've mentioned, but it's getting it into the right spot. So you have to have very skilled physicians in the area of interventional radiology that know how to get to tumors and been doing it for a long time, and know how to feed and saturate the area with the right medicines. The goal here is for patients to have a safer treatment that helps them live longer, helps have a better response, helps them to go into remission. That's the key behind Chemo-Immuno Precision Injection. And that's why we're very excited about this paper and this patient having a very positive outcome with a very late stage complex tumor, and his immune system turning on and the treatment finally working to improve their quality of life. So here are the steps that I think each patient can take that aren't too hard. You should ask your doctor, are there interventional oncology treatments available for my cancer? Are they being done? Can you track my circulating tumor cells, my CT-free DNA, my methylation scores to give me me leading indicators to see if my treatment is working. Can you do immune profiling with spatial biology so you can see what my immune system really needs and custom build the treatment with the goal of helping my immune system fight the cancer? I think these are the questions you should ask any oncologist or doctor you're working with, because if those tools aren't being used, I dare to say you're not getting the best care, you're getting standard of care, which is okay and helpful for some patients. But with complex and difficult cancers, it's not the state of the art. So if this episode has helped kind of open your eyes and it's something you want to share with people that it might help, I want to encourage that. And I know I'm going to be asking for something that I normally don't ask for, but about 90% of the people watching this aren't subscribed yet. Now, the reason I say that it's important is because by you subscribing, you're not just helping the channel, you're helping us get the message out to people all over the world that there are options for cancer, that cancer is not stuck in the old model, that we can change cancer into precision oncology. So by you subscribing, it plays with the YouTube algorithms and says, hey, push this content out so more people around the world can hear, doctors can hear, patients can hear, and together we can change oncology so that people can live longer with a better quality of life and move forward these precision targets and help maybe even insurance companies cover this care for patients. That's the goal, really. So I hope this was helpful, and may the Lord bless you on your journey to healing.